Okay, let's get started. Today's agenda will focus on the changes that are upon us and how population health management is now very essential to healthcare. We'll also talk about assessing readiness to take on population health and how to successfully move forward in this challenging healthcare environment. I'm certain that everything noted on the page, next slide please. Oops. I'm not, there we go. It looks like it's coming in. I'll keep going, guys, just so we stay on time. So when you see this slide, I would think that what is on this page is familiar to most of you. Reimbursement cuts continue. Cost reduction is certainly a way of life, especially since payments don't even begin to cover the cost of delivering care in some areas. Payer negotiation many times aren't very negotiable, and then certainly and most likely pay for performance is here to stay. Next. If we look at where we're headed, change is absolutely going to escalate. Competition is clearly extending beyond the acute care walls, and aggregation is occurring at a rapid rate and may include players that were typically outside of your market share or local community. When partnering with stakeholders, physicians, SNFs, rehab, home health, outpatient facilities, typically these are the entities that readily come to mind. You should also, though, think about partnerships with your local business and government leaders, which is, for some of you, I would think, a very new concept. They should have a vested interest in partnering with you in order to gain economic and social benefits of living in a healthier community. So it makes sense to start thinking of them as potential partners in healthcare. Engaging physicians and creating stakeholder partnerships can really help to assure that providers are working to optimize patient outcomes within a select cost structure. Disruptive change isn't necessarily a bad thing. Consider this as an opportunity to actually use change to your benefit. If you recall, when you registered for this webinar, we asked the question that is noted on this slide, and so we just want to share some results with you. 44% said that they are pursuing shared savings, value-based, or at-risk contracts. 32% are not, and 24% aren't sure. So as you can see, nearly half of you are moving toward at-risk contracts, and this is clearly a shift from where healthcare has traditionally been in healthcare. Next slide, please. So if you look carefully at this slide, you can see in today's environment, healthcare systems really need to balance changes in two contrasting and at times even competing environments. First is the acute care model, where most healthcare delivery systems have traditionally been focused. And now we have emerging transformation that really encompasses the entire continuum of care. The result of managing the pressures of surviving today while planning for the changes of tomorrow have basically created three areas of focus for healthcare systems. First, it's necessary to optimize cost and quality in the acute care model, primarily with the intent to really remain relevant and competitive within your existing acute care market. At the same time, clearly a need to assess and stage the who, what, when, where, and how of transformation as we move into the new model, and this involves obviously integrating across the care continuum. And finally, in order to navigate and survive in both of these environments, there really is escalating pressure to align and engage physicians in ways that are different than we've ever seen in the past. With the Health Care Act coming alive in 2014, it will quickly become evident that hospitals cannot possibly do all of this work alone, and they really need to step up and step out of the four walls of the acute care setting. So working with partners and stakeholders to move forward in communities, accomplish better health for overall, will really be a major focus. The intent of healthcare going forward is not just for the hospital to make patients well, but also to keep them well when they are really outside of that acute care or hospital setting. Next slide, please. Payment models are definitely moving away from our traditional fee-for-service, where providers typically address acute care needs or patient illness, and we're moving to a future of value-based and accountable care models with a major focus on population health. Going forward, the emphasis will be on keeping patients well and out of the acute care system. As providers take on significant financial risk, they'll need to be savvy in wellness, prevention, disease management, typically outside of those acute care walls. The question to ask is, are hospitals and healthcare systems well positioned for value-based models of care? At this time, I would say for many, the answer is not yet. Next, please. And a first step toward pursuing population health is to assess your organizational readiness to really take on population health management. Completion of a readiness assessment that includes many of the key aspects of population health that are noted in this slide will help organizations evaluate their current ability to pursue population health management. Next, please. By now, I think you get the point. The changes here, and in this change environment, what we're feeling is very different than what we've previously experienced in healthcare. Even those of us that have been around for many years haven't previously experienced this dramatic of a move toward population health. Next. On this next slide, you'll see that organizations are clearly in tune with the move from volume to value. The question is, how will organizations actually accomplish the move and then succeed in this new environment? If you look at the next slide, it'll show that you have a snapshot from HRAT's May 2012 survey on readiness to move to population-based accountable care. As you can see, many of the responses lean toward the more challenging end of preparing for the ACO environment. Given this information on the slide, and knowing that as of January 2013, there were about 430 ACOs, it's clear that organizations understand the need to move toward population-based accountable care, even though it may be a difficult journey. Next slide, please. I assume that many of you are familiar with the triple aim, which is designed to improve the health of the population, enhance the patient experience, and reduce or at least control the per capita costs of care. As you can see on this slide, there are several care and payment models in play that can help to drive the triple aim. I think one model worth noting is the patient-centered medical home, since many of the components of a patient-centered medical home are well aligned to help organizations address the triple aim and population health management. I think it's also worth noting that many of the key components of a patient-centered medical home align with the components of a population health readiness assessment. As you think about next steps, you may want to consider completing a population health readiness assessment, become familiar with the triple aim, and then identify your population health organizational strategy, as these are all fundamental to population health management. At this point, I'm pleased to turn the presentation over to Karen Handmaker. Go ahead, Karen.
Thank you, Marilyn. And I think it's pretty clear that there's no escaping population health as we're moving ahead in population health and healthcare today. So on this next slide, you can begin to see quite quickly that all roads lead to population health. Meaningful use drives the use of health information technology, so we have the ability to report across populations and communicate across providers. CMS and the Affordable Care Act are encouraging many population health-based initiatives such as quality improvement with an emphasis on chronic care management and prevention. And new models of delivering and financing health care, such as the patient-centered medical home and accountable care organizations, have population health and the AAA principles at their core. Next slide. You can also see the increasing importance of population health in the evolution of new payment models. As payment becomes more tied to quality and savings versus volume, the need for a population health-oriented infrastructure becomes crucial. Or, to put it another way, the faster payment incentives change from maximizing volume to maximizing quality and savings, the faster health systems like yours will transform to population health. And this is exactly the tension that Marilyn was describing in this rapidly changing environment. Next slide. Historically, it has been very common for provider organizations to focus on the top 3% of patients because they are the most costly and complex patients, and they also show up. These patients do deserve the attention they receive. However, in a population health-oriented model, there are two key points to understand about this strategy to focus on the top 3%. First of all, if you manage very intensely on the top 3% this year and do a really good job, it will not reduce the cost of the top 3% next year, because most of the individuals in the top 3% change from year to year. Therefore, to improve overall cost trend, which is critical in the ACO and shared savings models, It is imperative to prevent people from becoming acute and complex in the first place. And the only way to do this is to look below the proverbial waterline to identify and manage patients who are at risk and have known chronic conditions while keeping healthy people healthy. So now let's turn to what Marilyn started talking about, assessing readiness for population health. In the ideal, population health requires a bottom-up approach, starting with what's on the right side of this slide, the infrastructure and the best practices on the front line to manage patient populations effectively, whether one patient or cohorts of patients. This bottom-up approach will allow health systems to succeed on your overarching strategic goals, such as becoming an ACO or a clinically integrated network that's highly functioning, and your financial objectives, such as maximizing quality and shared savings incentives. Next slide. Another survey question that we asked you upon registering for this webinar was about whether you're pursuing patient-centered medical home. The fact that so many of you are tells me that many of you are already preparing your infrastructure for population health. This is certainly one of the obvious early indicators. And this is exactly what I would expect because you are also pursuing or already involved in ACOs or other value-based contracts that also depend on population health. So on this slide, let's take a look. We've done many population health readiness assessments between Marilyn and myself, and this slide illustrates what we're seeing in the marketplace, and this may even apply to your organization as a snapshot. Many health systems do have clear goals, and they may already be accepting contracts with pay-for-performance or shared savings components, as you can see on the left-hand side of this slide. But their ability to manage populations is definitely still emerging. This bottom-up side, if you will, as I referred to it earlier on the right side of the slide, are much slower to come up to par. And this is what we're going to talk some more about. On the next slide, just to try to make it a little bit more real, and maybe you can relate to this from your health system, think about this kind of a profile and think about whether these types of things apply to your system. In many cases, the organization has done a lot to prepare for population health, such as the things on the top half of the slide, but there's still a lot of gaps, as you can see on the bottom half of the slide, around effective data, tools, and patient engagement strategies to be able to manage both above and below the waterline we described to achieve your goals. Next slide. Okay, so now we're going to talk about closing those gaps between what you really need to succeed in population health and what you already have. So for those of you who have worked in organizations that have embraced Lean or Lean Six Sigma methodologies to drive your transformation to population health, you will know that keeping the end in mind is one of the key principles and certainly aligns with the idea of a bottom-up approach. So now on this slide about big data, the first thing that many organizations do is get their house in order in terms of data. Population health requires health systems and provider organizations to have what is often referred to as a big data solution. This refers to a data model or warehouse or data mart, any number of names and terms, that integrates many data sources, applies algorithms for analytics and reporting, and tees up actionable information for care teams, quality leaders, and financial stewards across the continuum, across all of those stakeholders that Marilyn described at the beginning of our presentation. Next slide. This slide recalls the image of the iceberg and emphasizes that the operational aspects, the day-to-day aspects of managing populations are very significant in contrast to the effort to do the reporting. Specifically, the intelligent applications of big data and lean workflows are absolutely required to impact the results that will show up above that waterline in this picture. Next slide. To illustrate the point about the intensity of the operational requirements to succeed in population health, let's look at the ACO 33 measures. Many of you may be familiar with the ACO 33 because your systems are already engaged in these CMS initiatives for Medicare populations, as the survey question revealed. So let's just talk really quickly about what these ACO 33 measures encompass. There are 4 domains: patient and caregiver experience, care coordination and patient safety, preventive health, and at-risk population metrics. All of these measures require a significant effort to measure them and to improve them. Next slide. Now what I'm going to do is deconstruct a few of the measures to understand why a bottom-up approach will be required. This particular slide is ACO 9. It's about reducing hospital admissions for COPD and asthma in older adults that could have been prevented by better outpatient care. To improve on this metric, your primary care and specialist providers will need to identify patients with these conditions who are at risk for exacerbations that could result in avoidable admissions. This means that actionable information from the big data applications will need to be in the hands of providers and care teams on a continuous basis, and they will need to have the resources to engage the patients that are identified as being at risk to better help them manage their conditions better, and any risk factors or other barriers to care that might prevent them from exacerbating and having to go to the hospital. The next slide highlights some other aspects of ACO 33 measures that require a similar bottom-up approach. First, there's 2 that are rather similar, number 16 and number 17. 16 is about weight screening and follow-up, and 17 is about tobacco use and cessation intervention. Both of these measures require 2 important things that are very granular and important to understand. First of all, at the front line, at the practice level, a workflow must be present at all practices that ensures patients are both screened for and counseled based on the measure criteria, whether it's weight and then follow-up for those who are considered obese. And second, for those who are smokers, they need to have a smoking intervention. The second important thing is that there needs to be a place in the electronic medical record to indicate that the requirements of these measures have been met and therefore can be reported. It is, as part of meaningful use, the whole drive to get people to use electronic systems is to facilitate the reporting abilities that I mentioned before. But if you don't put things in the same place every time in a structured field, it cannot be reported accurately or consistently. So in order to succeed on these measures, even though everybody says they're doing it, if it's not reported, it doesn't get measured and reported, and that's a problem. So this requires a very intense attention to process improvement and detail. Second, I'll go back to that previous slide, please. We're still talking about, I want to talk about diabetes for a moment. So second, the other area with the yellow highlights, for diabetes patients, the bar is even higher than what I just described. Organizations must meet all 5 of these outcome measures to pass. And each of these measures not only requires data in the hands of care teams to identify the patients who are not up to the therapeutic standards for A1C, cholesterol, and blood pressure, but they also need to work with these patients to help them manage their conditions more effectively. In other words, behavior change. So this bottom-up intensive approach is also required. These ACO 33 measures are not in every pay-for-performance contract. Again, we're talking specifically about Medicare ACOs, but many times commercial contracts and other forms of that pay-for-performance also are looking for performance on outcomes such as what I've just described with diabetes. So this is why the population health approach is so critical. Next slide. So now just think about your patient populations and think about patients with multiple conditions, and then understand that there are multiple metrics for each one of these conditions. So for an individual with many conditions, there will be many measures associated with that person, and then across thousands of patients, that adds up very quickly to thousands of measures. So care teams must have the information and the ability to manage to all of those metrics to be successful in the new world of population health management and value-based payment models. Next slide. With the application of technology, one can imagine the ability of care teams to engage and manage one patient as well as cohorts of patients much more effectively. This slide illustrates a sample of interventions that can be taken by having timely data, automated outreach, and empowered care teams. Next slide. Overall, the goal is to establish an ongoing process for managing populations that leverages data, analytics, and the ability to take action. And this is a nice summary slide, or a visual, if you will, that highlights the elements of best practices in population health, starting with being able to define the population and subpopulations you're managing, identify care gaps, stratify them to apply and allocate your resources, both human resources and other interventions and referrals, engage patients in their care, manage their care effectively, measure outcomes, and then keep repeating until you get it right. So this is an ongoing process and helps to make population health part of the DNA of any organization. Next slide. Here are the take-home messages so far that we'd like to leave you with, and then we want to open it up to questions. So I think that the first point is that the move from volume to value is clearly underway. Many systems, including many of yours, are already moving there. A scalable population management infrastructure is critical. Value-based incentives are all population-based. Care teams then need new tools to manage in this new environment, and data for patient monitoring engagement must be timely, actionable, and continuous. There's no doubt that these changes cannot take place with a heavy emphasis on cultural change. Marilyn, do you have anything else you'd like to add before we start taking questions?
Yes, Karen, thanks. I do have a couple of quick comments. I think that organizations really should consider evaluating competencies in some key focus areas. So they might consider looking at physician alignment, governance and leadership structure, community resources, acute infrastructure, patient access portals, patient engagement, certainly behavioral health capabilities as we move closer to patient activation, integration of technology and information. These are all areas that if you build competency in these areas, that will help you strengthen your ability to transition to population health management, and that goes in line with what you were saying, that culturally some of these changes need to occur. In line with all of that I just said, organizations can take a fairly simple next step. Pull together a team, complete a population health readiness assessment if you've not already done so. It's a great way to learn more about where you are and where you go with population health management. Lisa, let's open it up for questions.
Yes, thank you. We have some questions that came in through the question panel, as well as questions that we will be asking that were received during the registration. So the first question that came in was, where can we find population health readiness assessment tools? Anybody?
Lisa, I can take it. Yeah, this is Marilyn. I can certainly, for those of you that are VHA members, and I know we have several on the call today, VHA is actually very soon going to be offering a population health readiness assessment to all members. So if you're part of an organization like VHA, you can do that, and there is going to be word coming out to many organizations about that opportunity. I know that there are consulting firms and companies that offer assessments, and typically, you know, they're going to charge you a fee, but the fee is not, you know, monumental, and it's probably dollars that are well invested in order to be able to better understand where you currently stand in relation to population health and being ready for both the cultural changes as well as the financial risk. Karen, do you have anything to add as to where resources might be?
Yep. FITEL also offers organizations that are interested in our services a high-level population health readiness assessment to determine, again, where you are and how automation and automated tools and services can support your care teams and your objectives. In addition, organizations that put out standards for patient-centered medical home and accountable care often have readiness assessments that you can take, sort of self-evaluations, if you will. So there are plenty of resources out there on the web if you want to go and look for them.
Okay, thank you. The next question that came in was, where can we find competencies on the topics that you've mentioned, i.e. physician alignment?
Well, again, this is Marilyn. There are many, many organizations out there that right now that are offering services that in relation to physician alignment. Again, and I'm certainly not pushing VHA, but we absolutely do have the capability within VHA to support organizations as they move toward physician alignment. So if you're, again, a VHA organization, we want to make you aware of that. And there are several consulting companies that offer that services. And typically when you're getting into physician alignment, that's going to be a component of the readiness assessment that, that you'll be asked. And then from that readiness assessment, you'll be able to identify where your strengths and your opportunities are, and then make best decision. Is this something that you can tackle internally, or do you need to go outside of your organization to identify where those resources are? And certainly Karen and I can help you with any questions or follow-up resources that you may need. And again, it's not to push VHA or FITEL. We certainly know where those resources are for both of our organizations. But if we don't have them to support you, we absolutely want to point you in the right direction. So we're happy to help in any way that we can. Again, we want to escalate this move to population health for organizations, make it as easy as possible. Karen, do you have anything?
There's another component, Marilyn, that we didn't explicitly mention as part of our discussion today, and that is provider compensation. Oftentimes there's a lag between the incentives that the enterprise has in terms of pay for performance on quality and shared savings, and yet provider compensation is often still in a volume-based mode. In other words, the more people you see, the more services you perform, the more beds you fill, the more money you make. And we're in that sort of transitional phase, if you will. It's never going to go to 100%. I'm sure there will always be components in payment models that are around fee-for-service or volume, and physician compensation will remain tied to volume to some degree, but the proportions are going to shift. And so I think as you're thinking about physician alignment, it's also important to think about ultimately how you need to align how you pay providers to match up with the organization's incentives.
Right, and Karen, if I might just jump in again, it's not just strictly financial incentives. It's all about the quality and the value that's being delivered. What are those outcomes? And we're seeing more and more organizations have a far greater part of their compensation tied to quality outcomes and not just financial incentives.
Okay, thank you. Next question came in through the chat. This is, do you have any suggestions or tools for identifying the at-risk patients other than the poorly controlled chronic disease patients that are just under the waterline?
I'll be glad to take that one, Lisa.
Okay.
There's lots of tools out there that you should think about, and many of these types of tools have been used for a long time through health plans and through the vendors of wellness programs and disease management programs, but are now just coming to a provider organization near you. And what I'm referring to are things like health risk assessments and plan design and things like that that can help identify patients who or members who may be healthy but have behavioral health risks that need to be addressed, and encouraging them to change those behaviors to prevent the onset of chronic conditions or the exacerbation of chronic conditions. The other types of things are, there are lots of predictive models in the marketplace. So as part of that big data solution, oftentimes there will be models that use claims data to identify people based on past costs and past utilization patterns, and any additional clinical information or HRA data that they can get to anticipate who might be at risk based on information that's collected, and then coupling that with what the care team members might know about those patients from their personal work with them.
Okay, thank you. Okay.
Guys, if I just want to, sorry, Lisa, I just want to add that, you know, some people think that the be-all, end-all tool is the electronic health record, but don't get caught into that trap, because that truly is not the solution or the answer. Those, you know, having the EHR certainly is a helpful component, but I think it's much more important to move, as Karen said, toward understanding the aggregation of the big data and lots of data, and it's got to be the right data. So, you know, just going out there and collecting anything and everything that you might have and throwing it into the soup really doesn't count. It's better, it's really understanding where you're coming from the payer perspective. What do those clinical outcomes look like? Financially, what is that impact? And then certainly not all of that data is produced within the acute care walls or within a health system. So going out and partnering with other entities that can supply that very crucial data is very important. So you do need to think of that as a tool in your toolbox that's extremely critical. Okay, sorry, Lisa, go ahead.
No problem. Let's see. This one came in. This one says, what guidance do you have that can help us manage our employee population through the continuum of care and linking our wellness program with our physician records and our insurance provider information?
I'll be happy to take that one, Lisa.
Okay.
I worked for many years in that environment, working with large employers and even smaller ones around how to manage their own employee populations. And I would just like to say that for any health system thinking of getting into the business of population health, there is no better testing ground than managing your own population using the same principles that Marilyn and I described here. One of the advantages is that it's a population that you can see and can impact through the data that you have. You have the claims, you have the levers of benefit design, where you can, for example, decide whether you're going to, what types of payments you're going to cover and what incentives to go to high quality providers you want to include. And then you also have the ability to you do a health risk assessment, offer on-site wellness programs, have preferred referrals to wellness programs that you want to incorporate, and even offer on-site clinics and on-site wellness programs that can support behavior change and a climate or culture of health, if you will, in your organization. So the first thing that I would recommend is taking a look at what you currently have with your benefits advisors and the status of your employee benefits, what kind of incentives are tacitly or implicitly included in the current plan design you have, and then working with your internal teams and your providers, as well as your benefits consultants, to determine how you want to change how that is done to realize more critical improvements. After you've done that, you'll be in a much better position to say to your community and to other employers in your area that, boy, we've done it successfully for our own employees, and we can take those lessons learned and the infrastructure we've developed to manage our own employees and then apply it to yours. Marilyn?
Nope, I don't have anything to add to that, Karen.
Okay, perfect. We actually have more questions coming in through the chat panel. Here's another question that came in. It says, have you seen a movement towards the use of computerized registries for a tool in population management? Were these EHR-based or outsourced?
You want me to take that, Marilyn?
Yeah, go ahead.
There, you know, the EMRs often provide tools that can create lists of patients that would take over, which would provide some of the functions of registries. But the term registry should not be considered something that is disease specific. It should really be a dynamic tool that your organizations can use to look at everything going on with each individual patient, but at the same time be able to quickly identify patients who need attention and being able to use that information to determine where you stand on any of the quality measures that we've been discussing. So there are registries that integrate with EMRs and other sources, but I think that the best ones are the ones that are able to integrate multiple data sources, such as demographic information and scheduling data and maybe HRA data and to some extent claims data to be able to complement what is in the EHR to help care teams manage patient populations more effectively.
Okay, thank you. Okay, I want to mix this up a bit with asking some questions that came in through the survey as well. How can population health management programs support the growing trend of value-based purchasing initiatives?
I'll take that one, Lisa. Once you get past the fact that providers are taking on financial responsibility and risk for an entire population of patients, then population health management just starts to make practical sense. Population health management can help providers become more efficient in the way that they care for a specific population. Providers can really focus on various levels of patient needs. You can reflect back on the iceberg slide that Karen showed us. We have patients that have complex needs. We have some that need to stay well and some that need disease management, and we can, extrapolate that list out into, become a very detailed list. But overall, providers really need to assess their services and treatments to determine if they're having the desired effect in all of those various segments of the population. So in essence, they can analyze the impact that they're having on a population, which is very important as organizations strive to succeed under the reimbursement models that now reward value and high quality rather than volume, just having patients show up and pay for the services rendered. So again, that very different environment. And so we need to get past the fact that, it isn't about the money, even though it really is. It's all about how do we better manage the population and keep them well.
Thank you. I have a question that came in through chat. This one says, it's a little lengthy, but it's a good one. The IOM has a roundtable that has been working to define population health and are leaning toward a definition that includes the broader population in a community or geographic area, and not just the subpopulations that are part of an ACO or who interacts with a specific health system. What strategies can you offer about true partnerships with community organizations that will result in improved population health?
I'll be glad to take that one, Lisa.
Okay.
I think that is a very perceptive question and a very important one, because if you stop and think about the ideas behind population health, these are not new. Public health is certainly a population health initiative in the biggest sense of the word. thinking about the health of all of our communities. And in many of the places where you live, and I'm sure many of the health systems that you come from are deeply involved in community health initiatives, such as around eating and around exercise and smoking cessation and other types of public health functions. But within what we're talking about here, everybody is thinking about, not all, as they form accountable care organizations, they have to think about working with members of the community, whether they are other institutions and facilities like nursing homes and ancillary providers and pharmacists and other types of groups like that. But they also need to be thinking about programs that support health education, that support smoking cessation, that support diabetes, that support mental health. And in fact, there are some studies out there, and I think Ohio is a state that has really made great inroads in these areas, and they have deliberately set out to create, if you will, lists of organizations that can support various types of population health initiatives that every community provider will use. And those kinds of systems help drive the continuity and the referral patterns that are important to driving improvements across a community. It's sort of like the whole boat will float higher when everybody is working together.
Yeah, I like that. Okay.
Lisa, if you don't mind, I'd like to add to that a bit.
Yeah,
true population health is really looking at the entire person and a population that falls within, whether it's a patient panel or market share. So the way we divide population and address population health management can be very different, but the ultimate in looking at truly population health is to realize it isn't about the diseases and just the medical management. And I think we have a tendency to go toward those disease states because, again, coming from acute care and moving into the world of population health management, disease states are mostly familiar to us. So transitioning at this point now makes it an easier step, if you will, to go to what we typically know and can address. But we need to get into the social, the economic, the behavioral, the environmental issues and the components that really affect care. And they could either enhance or be barriers. So stepping outside of those partnerships that I talked about earlier, the SNFs, the physicians, the outpatient facilities, et cetera, that we typically go to, this is where you really need to put on your thinking cap and get into the government, the civic leaders, the business leaders, because it does, in this case, as the words of Hillary, take a village. It really is about everybody pooling resources to best identify how they manage a select population. So a population in New York City that you're addressing may be very different than one in a rural place in the United States. So again, those environmental factors, the socioeconomic, demographics, absolutely will affect. So in essence, population health truly is about treating the physical, the emotional, the well-being of the community as a whole, but then still identifying where those subsets fall in that might need those types of resources that I just talked about. So it's a very different way of thinking, and I think that people are going to actually be successful when they step outside of the acute care walls and start looking to those other resources. People are wanting and willing to pitch in to as Karen said, raise all boats. So this is a great question and really a critical point about population health management.
I'm going to jump in and add another component here. The patient-centered medical home is a great example if you are already familiar with those standards, or and also ACO or clinical integration network standards are all mention the importance of integrating with community resources. No care manager can operate without knowing who else in the community could help an individual patient. So there's no way that a care team can do it all themselves, and they depend on community resources. But as an example, NCQA has proposed changes to their own 2011 standards for 2014, and within those proposed standards, which will become final next year at some point, will require organizations to maintain lists of community agencies that patients can be referred to, and particularly around the area of integrating behavioral health with physical health. So that level of integration could be everything from co-locating behavioral health resources within the practice, or just having established partners for providing those types of services. And I want to link this back because I know we're trying to cover a lot here, but that other question that came through about benefit design and managing employee populations, you know, that's another thing about making sure that, you know, that the resources that your employees need are included in some fashion in the benefit design that you create. So there's a lot there, but you definitely, whoever asked that question, definitely opened up a very important topic. Thank you for speaking up.
Agreed. Thank you very much. Another question that came in through chat is, today we're hearing a lot about the mechanics of population health management. Can you speak more directly to the required cultural changes needed?
Marilyn, you want to do that one?
Yeah, I think, you know, number one, understanding the governance and leadership structure of your system. How do you relate to the components that will really have primary responsibility for managing population health? So very important that you understand where that leadership structure stands, what the culture is coming out of leadership, and even wanting to move outside of the acute care walls. That in itself may be a struggle. Do you have any connections or ties in those areas? We already talked a bit about physician alignment. Again, extremely critical. And it's not just aligning with physicians that you may employ as a health system or an organization, because that will only take you so far. Typically, you have to start looking to those physician groups or individual physicians, especially for those that have more scattered populations, and align with physicians and providers that are typically outside of your employ. So extremely important to open that door culturally, and then obviously once you do, trying to blend those different entities into your organization. And that could go also for the other partnerships that we've talked about. Blending them into your culture is could be very much a challenge, again, without the right structure and leadership in place that it truly embraces and endorses the need for this connectivity. We know that partnering with the post-acute entities, very, very important, because the intent is to keep people well and out of the acute care walls. So culturally, is your organization even ready to do that? Where, you know, might your contract still lie? When we talked about the persons moving to risk, we said 44 of the organizations are moving in that direction. That means that just as many, half, are not moving in that direction. So how will those organizations fare if they're not, if the risk is imposed upon them and they're not willing to take it on? So culturally, you really have to prepare financially for this shift in your mindset and your thinking, and then set up your resources to appropriately address where it is that where you may be going that really is outside of your direct control. So again, extremely important that leadership is understanding where they're going, and then tying back to those community resources. Remember, everybody now is going to have a vested interest. So what does your board look like for your community? What we typically see, you know, is a board or foundation that's very much related to the acute care, serving an acute care facility or acute care health system. Do we need to restructure culturally what that looks like and engage those people from the community that are going to be able to move you in a new direction? Does this ship turn around overnight? As Karen said, no. This is a huge ship. It's a long and arduous journey, and it's going to most likely be a continuous journey. So tackling the cultural issues is paramount, but critical, and I'm a strong believer that you start with governance and leadership and really understand where that sits and go from there. And we could talk all day about this, but obviously I want to give time to anybody else. But Karen, I don't know if you have anything to add.
Well, I think that what you said is right on, but the other piece of that is that you also need a bottom-up approach, and that means not only putting the right people from across your network on your boards and into your committees, but it also means educating people on the front lines about what this change means, so they can begin to embrace it and begin to help move the organization toward your goals. So, for example, population health standards, patient-centered medical home standards require care teams to understand what population health is all about. So it takes leadership to recognize that, to carry out that type of education. Providers need to understand it. Like I said, care teams need to understand it, and all your stakeholders need to understand where everything is going. And it takes impassioned leadership, and it takes consistent leadership to be able to get that done.
And Karen, you reminded me of something else that I wanted to add, and it's in regards to that bottom-up approach, and I'm completely a believer in that, is that many organizations don't have the infrastructure for quality and process improvement that they do on the acute care side. So transitioning that type of knowledge into that outpatient or ambulatory or population health setting is very, very critical. And just taking what you know in acute care and putting it into settings where providers are going to be working within the scope of population health is not easily done. So again, finding the right people and the resources to support that and get that understanding of the need for process change, quality focus, understanding data is extremely critical. You've got to change the mindset of everybody that is touching a patient indirectly or directly. So moving forward in that direction is going to be something I think that we're going to see that's very different than what we've done in the acute care walls. When you're working with an office with only 3 persons in it, all of them need to know. They may have a significant panel of patients. All of them need to know what their role is in order to drive population health. So extremely critical. Karen, I couldn't agree with you more to get to that grassroots level.
Yeah, agreed. Okay, well, we actually have time for one more question before we close out. And I want to go back to the questions that we received during our registration. And this one was, what are the main challenges for provider organizations that are trying to implement population health initiatives? Karen or Marilyn?
Would you say that one more time, please, Lisa?
What are the main challenges for provider organizations that are trying to implement population health initiatives?
I can take this one.
Sure.
I think many of the providers are not yet using all the right tools. I think we talked about that before. They're focusing on implementing their electronic health records and focusing strictly on those disease states. So, where do we start and how do we move into population health? I think you're going to find that your primary challenges are around the technology and around the governance and the leadership infrastructure and the cultural changes that need to occur. Change management is extremely crucial in understanding how you move forward. Karen, I don't know if you have anything to add to that, because I think we've actually, in many of the other questions, addressed some of these challenges.
Mm-hmm. I think we've covered it well. I think that the challenges are multifaceted, and with the right leadership and the right game plan, they're achievable.
Yeah, what you said is very. Do people even have a strategic plan in relation to population health? What does that look like now from the acute care side and being a health system and encompassing a strategy that typically is, yes, you absolutely, had community benefit. You touched upon the work outside of your acute care walls, but this is a very different strategic approach to really serving people in a very, very different way.
Great. Okay, well, Marilyn and Karen, I want to thank you both for your time and the responses to the great questions that came in. That's all the time we have for now, everyone. On behalf of VHA and FITEL, I want to thank you for joining us today. We also have another webinar scheduled for September. Our guest speaker is Orlando Health, who will be discussing the journey to population health management, embracing healthcare IT to drive effective clinical integration. So we look forward to seeing you there. Again, we want to thank everybody for joining us, and we hope everybody has a safe and happy holiday weekend. Thank you again, everybody.
Thank you, Lisa.
Thank you.